My name is Sarah, and I've been working as an OR nurse for 12 years. 12 years of watching doctors play God. 12 years of being treated like I'm invisible. 12 years of knowing that behind the pristine white coats and fancy degrees, some of these people are absolute monsters. But nothing, and I mean nothing, prepared me for what I witnessed with Dr. Marcus Evans and what I had to do to stop him. Let me paint you a picture of Dr. Evans first. Tall, silver-haired, with those piercing blue eyes that made every nurse in the hospital flutter like schoolgirls. He was the kind of surgeon who walked into a room and demanded attention without saying a word. 20 years of experience, department head, published researcher. The man was basically medical royalty. Everyone respected him, feared him, wanted to be him or be with him. He had this way of speaking that made you feel like he was doing you a personal favor, just by acknowledging your existence. The patients adored him, calling him their miracle worker and angel in scrubs. But I knew better. I always knew there was something dark lurking beneath that perfect exterior. It started 3 months ago with Emily Chen, a 24-year-old woman with a rare autoimmune condition that required frequent surgeries and extended hospital stays. Emily was what we call a frequent flyer, someone who becomes almost part of the hospital family because they're here so often. She was sweet, vulnerable, and completely dependent on our care. Her condition left her isolated from friends her age, and she'd often joke that the hospital staff were her only social circle. That should have been our first red flag. A young, lonely, vulnerable patient who looked up to her doctors like they were saviors. Dr. Evans took a special interest in Emily's case from day one. At first, I thought it was professional dedication. He'd spend extra time explaining procedures to her, checking on her progress personally instead of sending residents, making sure she had everything she needed. But then I started noticing things that didn't sit right with me. Things that made my stomach turn and my professional instincts scream that something was very, very wrong. The first thing I noticed were the late-night visits. Dr. Evans would show up to Emily's room at 9, 10, sometimes 11 at night, way outside normal visiting hours, and definitely outside his scheduled rounds. I'd be doing my evening medication rounds, and there he'd be, sitting by her bedside, talking in hushed tones, laughing at her jokes like they were old friends. When I'd enter the room to check her vitals, the conversation would immediately stop, and he'd give me this look. Not quite threatening, but definitely a warning that I wasn't welcome. Then came the gifts. Small things at first. Magazines, flowers, fancy chocolates that definitely didn't come from the hospital cafeteria. I'd arrive for my shift and find these little tokens on Emily's bedside table. When I asked her about them, she'd light up like a Christmas tree, gushing about how Dr. Evans is so thoughtful and how he really cares about his patients. The way she said his name, with this breathless admiration, made my skin crawl. This wasn't normal doctor-patient interaction. This was grooming. First CTA break. If you're just joining us here on Hospital Revenge, make sure to hit that subscribe button because you're about to hear a story that will make you question everything you think you know about the people we trust with our lives. The battles fought in hospital corridors aren't always about life and death. Sometimes they're about power, manipulation, and the courage it takes to stand up when everyone else is looking the other way. This is one of those battles. And trust me, you won't want to miss how it ends. The situation escalated when I started paying closer attention to Emily's medical records. Dr. Evans had mysteriously become involved in aspects of her care that were way outside his specialty. He was a cardiovascular surgeon, but suddenly he was consulting on her rheumatology treatments, her pain management, even her psychiatric evaluations. He was inserting himself into every aspect of her medical care, creating a dependency that went far beyond what was appropriate or necessary. I watched as Emily became more and more attached to him, talking about him constantly, asking specifically for him when she had questions or concerns, even refusing to discuss her treatment with other doctors when he wasn't available. She'd save up stories and jokes to tell him during his visits, dress up more carefully on days when she knew he'd be doing rounds, and I could see the way her whole demeanor changed when he walked into the room. She was falling for him, hard, and he was absolutely encouraging it. The prescription patterns were what really caught my attention. Emily's pain medication dosages were consistently higher than what her condition typically required. Dr. Evans was prescribing powerful opioids for procedures that usually warranted much milder pain relief. When I subtly questioned this during team meetings, he'd brush off my concerns with that condescending smile and remind everyone that he had extensive experience with pain management and chronic conditions. But I knew what I was seeing. He was keeping her dependent, keeping her grateful, keeping her coming back. The breaking point came when I discovered he had been rearranging surgical schedules to ensure he was always Emily's primary surgeon, even for procedures that other specialists should have been handling. He was performing operations outside his expertise, putting her at unnecessary risk, all so he could maintain his position as her savior. This wasn't medical care anymore. This was possession. I started documenting everything. Every inappropriate visit, every unnecessary prescription, every surgical decision that prioritized his access to Emily over her actual medical needs. I kept detailed notes, took photos of prescription bottles, recorded dates and times. I knew that if I was going to challenge someone with Dr. Evans' reputation and power, I needed to be absolutely bulletproof in my evidence. The night that changed everything was a Tuesday in October. Emily was scheduled for what should have been a routine arthroscopic procedure to address inflammation in her knee joint. It was a simple surgery, something that could have been handled by any orthopedic surgeon in the hospital. But Dr. Evans had somehow maneuvered himself into being the primary surgeon, claiming he had unique experience with autoimmune complications in joint surgery. It was complete nonsense, but no one questioned him because, well, he was Dr. Marcus Evans. I was assigned as the circulating nurse for the procedure, which meant I'd be in the OR, but not directly assisting with the surgery. As Emily was being prepped, and the anesthesia was taking effect, I was reviewing her chart one final time, when something caught my eye. Her recent blood work showed elevated liver enzymes, likely a side effect of the high-dose pain medications she'd been prescribed. This was a significant finding that could affect anesthesia protocols and post-operative care, but it wasn't noted anywhere in the surgical plan. I approached Dr. Evans, who was scrubbing in, and quietly mentioned the blood work results. Dr. Evans, I noticed Emily's liver enzymes are elevated. Should we adjust the anesthesia protocol or consider postponing until we can evaluate further? It was a reasonable, professional question based on legitimate medical concerns. Any responsible surgeon would have at least paused to review the numbers. Instead, Dr. Evans turned to me with this look of absolute disdain. In front of Emily, who was still partially conscious, in front of the entire surgical team, he laughed. Actually, laughed. Then he said the words that would seal his fate. "Relax, Sarah. I know what I'm doing. You're just a nurse. Now, hand me the scalpel. Just a nurse." Those 3 words hung in the air like poison. I felt my face burn with humiliation as the entire surgical team awkwardly looked away. Emily, even in her sedated state, had heard it. I saw the flicker of confusion and disappointment in her eyes before the anesthesia fully took hold. In that moment, I realized that Dr. Evans wasn't just manipulating Emily. He was so arrogant, so drunk on his own power, that he was willing to dismiss legitimate medical concerns to maintain his image of infallibility. But what made me truly sick was that he had humiliated me specifically in front of Emily. He wanted her to see him putting me in my place, wanted her to understand the hierarchy, wanted her to know that only he had the knowledge and authority to take care of her. It was a power play designed to further cement her dependence on him, and he had used my professional concern for her safety as a weapon to do it. Second CTA break. I want you to pause right here and think about this moment. When does loyalty to a colleague end and responsibility to a patient begin? When do we stop making excuses for people in positions of power and start protecting the vulnerable people who trust us with their lives? Drop a comment and let me know your thoughts. And if this story is hitting you as hard as it hit me, smash that like button, because we're just getting started. The surgery proceeded without immediate complications, but I spent every minute of that procedure planning my next move. I wasn't just angry about being humiliated. I was terrified for Emily's safety and disgusted by what I was witnessing. Dr. Evans was so focused on maintaining his inappropriate relationship with her that he was making medical decisions based on personal motives rather than professional judgment. This wasn't just unethical, it was dangerous. That night, I went home and pulled out every piece of documentation I had been collecting. I spread it all out on my kitchen table like some kind of detective trying to solve a case. Prescription records, surgical schedules, nursing notes, visitor logs. Everything painted a clear picture of a doctor who had crossed every possible professional boundary. But I knew that wasn't enough. Powerful men like Dr. Evans don't fall because of whispers and accusations. They fall because of irrefutable evidence and systematic documentation. I spent the next 2 weeks being the most meticulous nurse I had ever been. I documented every single interaction between Dr. Evans and Emily. I photographed the gifts he brought her, noting dates and times. I recorded conversations where she expressed her romantic feelings for him, where she talked about how special their relationship was, how he understood her in a way no one else did. I documented the increasing frequency of his visits, the way he would dismiss other medical staff when they tried to provide her care, the way he was isolating her from the broader medical team. Most importantly, I focused on the medical negligence. I compiled a comprehensive list of every decision he had made regarding Emily's care that prioritized his personal access over her medical needs. The unnecessary surgeries, the excessive pain medications, the procedures performed outside his specialty, the dismissal of legitimate medical concerns from other staff members. I created a timeline that clearly showed how his inappropriate personal relationship was directly impacting the quality and safety of her medical care. I also reached out to other nurses who had worked with Dr. Evans, carefully and discreetly asking about their experiences. What I discovered was a pattern of behavior that went back years. Multiple nurses reported feeling uncomfortable with his interactions with certain female patients, particularly younger women who were frequent admits. There were whispered concerns about boundary violations, inappropriate gifts, excessive personal attention. But no one had ever reported it because, well, he was Dr. Marcus Evans. Who was going to believe a nurse over the department head? The more I dug, the more disgusted I became. Emily wasn't his first victim. She was just the most recent in a long line of vulnerable women he had manipulated and exploited. The man who was supposed to heal people was systematically preying on them when they were at their most vulnerable. And the entire hospital system had enabled him by looking the other way, by making excuses, by prioritizing his reputation over patient safety. I knew I had to be strategic about how I approached this. Going directly to hospital administration or the medical board with accusations of an inappropriate relationship would be my word against his, and we all know how that usually ends. But focusing on patient safety violations, medical negligence, and professional misconduct, that was different. That was documentable, verifiable, and undeniable. I spent hours crafting my report, making sure every single claim was backed up by concrete evidence. I didn't mention the word affair or relationship anywhere in the document. Instead, I focused on the pattern of medical decisions that compromised patient care, the boundary violations that created an unsafe environment, and the professional misconduct that put multiple patients at risk. I framed it entirely in terms of patient safety and professional standards. The report was 15 pages long, with detailed timelines, supporting documentation, and witness statements from other staff members who had observed concerning behavior. I included copies of prescription records, surgical schedules, visitor logs, and nursing notes. I created a comprehensive picture of a doctor whose personal interests had corrupted his professional judgment to the point where he was actively endangering patients. 3 weeks after the humiliating incident in the OR, I requested a meeting with the hospital's chief of staff, the director of nursing, and the head of human resources. I told them I had serious concerns about patient safety and professional conduct that required immediate attention. When they asked for specifics, I handed them my report and said, "I'm here to document a pattern of behavior by Dr. Marcus Evans that compromises patient care and violates multiple professional standards. I believe this creates significant liability for the hospital and immediate danger for at least one current patient." The room went completely silent as they began reading. I watched their faces change as they processed the information, initial skepticism giving way to concern, then alarm, then barely concealed panic as they realized the legal and professional implications of what I was presenting. This wasn't just about inappropriate behavior. This was about malpractice, negligence, and potential criminal conduct. Within 48 hours, the hospital had launched a full internal investigation. Dr. Evans was immediately suspended pending review. and Emily was transferred to the care of another physician. The investigation team interviewed dozens of staff members, reviewed years of medical records, and conducted a comprehensive audit of his patient interactions. What they found was even worse than what I had documented. The pattern of inappropriate relationships went back over a decade, involving at least 6 different patients. There were financial irregularities where he had been billing insurance companies for unnecessary procedures and consultations. There were prescription violations, where he had been overprescribing controlled substances to maintain patient dependency. There were surgical complications that had been covered up or misreported to protect his reputation. The state medical board launched their own investigation, and within a month, criminal charges were filed for prescription fraud, insurance fraud, and sexual misconduct with patients. The hospital settled multiple lawsuits from former patients who came forward with their own stories of manipulation and abuse. Dr. Evans lost his medical license, was banned from practicing medicine, and ultimately served 18 months in prison. Emily was devastated when she learned the truth about her special relationship with Dr. Evans. She had genuinely believed that he cared about her, that their connection was real and meaningful. Learning that she had been manipulated and exploited by someone she trusted with her life was almost more traumatic than her original medical condition. She required extensive therapy to process the betrayal and abuse. But with proper medical care from ethical physicians, her condition actually improved significantly once she was no longer being over-medicated and over-treated. The day Dr. Evans was escorted out of the hospital by security was one of the most satisfying moments of my career. I watched from the nursing station as he walked down the corridor with his head down, carrying a cardboard box with his personal belongings, his reputation and career in ruins. The man who had once commanded respect and fear was now just another predator facing the consequences of his actions. But here's what I want you to understand. This wasn't just about revenge. This wasn't about getting back at someone who had humiliated me or made my job difficult. This was about protecting vulnerable people from someone who was systematically abusing his position of power and trust. Emily and the other women he had victimized deserved justice, and the patients who would have been his future victims deserved protection. The investigation revealed that multiple staff members had suspected inappropriate behavior over the years, but no one had been willing to speak up because of his position and influence. Fear of retaliation, concern about being believed, worry about damaging their own careers. All of these factors had allowed him to continue his predatory behavior unchecked. It took one person being willing to document everything meticulously and present it in a way that couldn't be ignored or dismissed. I learned something important from this experience. The system only works when people are willing to make it work. Policies and procedures and professional standards mean nothing if no one is willing to enforce them. Evil flourishes when good people stay silent, and sometimes being a patient advocate means being willing to go to war with people who seem untouchable. The aftermath wasn't easy for me either. There were colleagues who resented me for ruining a good doctor's career, who felt I should have handled things differently, or given him a chance to explain himself. There were administrators who were uncomfortable with how thoroughly I had documented everything, who worried about what other problems I might uncover if I decided to investigate them. But there were also patients who were safer because of what I did, and women who would never become victims because a predator had been stopped. Final CTA break. So here's my question for you. What is the best kind of revenge? Is it the kind that just punishes the person who wronged you? Or is it the kind that protects innocent people while ensuring justice is served? If this story has made you think about the power dynamics in healthcare, the importance of speaking up for vulnerable people, or the courage it takes to challenge authority when lives are at stake, I want to hear about it in the comments. Hit that like button if you believe that sometimes the best revenge is simply making sure the truth comes to light. And subscribe to Hospital Revenge, because these stories need to be told. The battles fought in hospital corridors, the courage of healthcare workers who refuse to stay silent, and the justice that can be achieved when someone is willing to stand up for what's right. Today, I still work as an OR nurse, and I still see doctors who think they're above the rules, administrators who prioritize reputation over safety, and systems that protect powerful people at the expense of vulnerable patients. But I also know that one person with documentation, determination, and a commitment to doing what's right can make a difference. I know that predators can be stopped, that justice can be achieved, and that sometimes the people who seem most untouchable are actually the most vulnerable when their crimes are exposed to the light. Dr. Marcus Evans thought he was untouchable. He thought his reputation, his position, and his influence made him immune to consequences. He thought he could manipulate vulnerable women, dismiss concerned staff members, and prioritize his personal desires over patient safety without anyone having the courage or ability to stop him. He was wrong. I'm just a nurse. But being just a nurse means I'm a patient advocate, a safety monitor, a truth teller, and sometimes, when necessary, the person who brings down the monsters who hide behind white coats and medical degrees. And I would do it again in a heartbeat. That's my story of hospital revenge. Not revenge motivated by personal grievance, but justice motivated by professional responsibility and human decency. Sometimes the best revenge isn't about getting even. It's about making sure the truth is told, the vulnerable are protected, and the people who abuse their power face the consequences they've been avoiding for far too long. Remember, in the halls of hospitals across the world, there are battles being fought every day between those who would abuse their power and those who refuse to let them. Sometimes those battles are won by someone who is dismissed as just a nurse, but who has the courage to document everything, the determination to see justice done, and the professional integrity to put patient safety above personal comfort. Dr. Evans learned the hard way that respect earned through fear and intimidation is just an illusion, and that when your crimes are exposed to the light, all the reputation and influence in the world can't save you from the consequences of your actions. The patients he victimized got justice. The women who would have been his future victims were protected, and the hospital became a safer place because one nurse refused to stay silent. That's the power of truth, documentation, and the courage to do what's right even when it's difficult and dangerous. That's what real revenge looks like. Not petty retaliation, but systematic justice that protects the innocent and punishes the guilty. And that's why I'll never apologize for being just a nurse who brought down a predator masquerading as a healer. But let me take you deeper into this story, because what I've told you so far is just the surface. The real story, the one that kept me awake at night and haunted my every step through those hospital corridors, is so much darker and more complex than you can imagine. The manipulation, the systematic abuse, the web of enablers and cover-ups that allowed Dr. Evans to operate for over a decade. That's the story that needs to be told in full. Let me start from the very beginning, from my first day working with Dr. Marcus Evans, because understanding how a monster operates requires understanding how they build their reputation, their network of protection, and their hunting grounds. It was 7 years ago when I first encountered him, fresh from a transfer to the cardiac surgery department, eager to work with what everyone called the best surgical team in the state. My first impression of Dr. Evans was overwhelming. He commanded the operating room like a conductor leading a world-class orchestra. Every movement was precise. Every decision was confident. Every word carried the weight of absolute authority. I watched him perform a complex valve replacement surgery that day, and it was genuinely impressive. His hands moved with the kind of precision that comes from decades of experience. His knowledge was encyclopedic, and his results were undeniably excellent. I understood why patients requested him specifically, why other doctors deferred to his judgment, why the hospital administration treated him like irreplaceable talent. But even on that first day, I noticed something that made me uncomfortable. During the surgery, Dr. Evans made several comments about the patient, a middle-aged woman named Margaret, that seemed inappropriate. Nothing overtly sexual or obviously unprofessional, but comments about her appearance, her personality based on their brief interactions, speculation about her personal life that had nothing to do with her medical care. The other staff members laughed along, treating it as harmless banter, but something about it felt wrong to me. After the surgery, I watched Dr. Evans spend an unusually long time with Margaret during her recovery, sitting by her bedside, holding her hand while explaining the procedure, making jokes that had her laughing despite her discomfort. Again, nothing that would raise immediate red flags, but something that felt like it crossed a boundary I couldn't quite articulate at the time. Over the following weeks, I started paying attention to Dr. Evans's interactions with different types of patients. With older men, he was professional, efficient, focused purely on medical matters. With younger men, he was mentoring and encouraging, often sharing stories about his own experiences. But with attractive women, especially those who were vulnerable, isolated, or dependent on long-term care. That's when I saw a different side of him emerge. He would spend extra time with these patients, not for medical reasons, but for what seemed like personal satisfaction. He would ask about their personal lives, their relationships, their fears and insecurities. He would position himself as not just their doctor, but as their confidant, their protector, their most important source of support during a frightening time. And these women, grateful for what they perceived as exceptional care and personal attention, would develop what I now recognize as trauma bonds with him. The pattern became clearer to me over months of observation. Dr. Evans had a type: young to middle-aged women, usually attractive, often dealing with chronic conditions that required multiple procedures and extended relationships with their medical team. Women who were socially isolated due to their health issues, financially stressed by medical bills, emotionally vulnerable due to fear and uncertainty about their conditions. Women who saw him as their savior, their lifeline, their most important relationship during the darkest period of their lives. I started keeping informal notes about these interactions, not because I initially suspected anything criminal, but because something about the pattern made me deeply uncomfortable as a healthcare professional. I had been trained to maintain appropriate boundaries with patients, to provide excellent care while keeping relationships professional and therapeutic. What I was observing felt like those boundaries were being systematically violated, even if I couldn't yet articulate exactly how or why. The first patient I remember being truly concerned about was Jennifer Walsh, a 32-year-old woman with a congenital heart defect that required multiple surgeries over the course of 2 years. Jennifer was going through a difficult divorce, had limited family support, and was struggling financially due to her inability to work consistently. Dr. Evans became not just her surgeon, but her primary source of emotional support, financial advice, and personal validation. I watched as he gradually isolated Jennifer from other members of her care team, positioning himself as the only person who truly understood her condition and could provide the specialized care she needed. He would dismiss concerns or suggestions from other doctors, claiming that Jennifer's case was too complex for anyone else to fully comprehend. He would schedule unnecessary follow-up appointments, order additional tests that weren't medically indicated, and find reasons to extend her treatment plan far beyond what her condition actually required. The gifts started small with Jennifer, just like they would later with Emily. A magazine he claimed reminded him of something she had mentioned, flowers from his own garden that he said would brighten her room, expensive chocolates that he insisted were left over from a conference. Jennifer was touched by these gestures, interpreting them as evidence of how much he cared about her well-being, how she was special among his patients. But I noticed that these gifts always came with subtle strings attached. He would mention how much time he had spent selecting the perfect magazine for her interests, how he had thought about her while working in his garden, how he had saved the best chocolates specifically for her. Each gift was positioned as evidence of how much she meant to him personally, how their relationship transcended the typical doctor-patient dynamic. The late-night visits began around the same time. Dr. Evans would arrive at Jennifer's room well after normal visiting hours, claiming he wanted to check on her progress without the distractions of the busy daytime schedule. These visits would last for hours, with hushed conversations, frequent laughter, and an intimacy that made other staff members uncomfortable. When nurses would need to enter the room for routine care, both Dr. Evans and Jennifer would act like they had been interrupted during something private and important. I started documenting these visits, noting the times, duration, and my observations about the interactions. At first, I told myself I was just being thorough in my patient care notes, but deep down, I knew I was building evidence for something I couldn't yet name. The professional part of my brain was screaming that something was wrong, even while my conscious mind was making excuses and trying to rationalize what I was seeing. The turning point with Jennifer came when I overheard a conversation between her and Dr. Evans that left no doubt about the inappropriate nature of their relationship. I was passing by her room during one of his late-night visits when I heard Jennifer tell him, "I don't know what I would do without you. You're the only person who really understands me, who makes me feel like I'm going to be okay. I think I'm falling in love with you." I stopped in the hallway, horrified by what I was hearing, waiting to hear Dr. Evans redirect the conversation, establish appropriate boundaries, Remind Jennifer that their relationship was professional, and that these feelings were a normal but temporary result of the vulnerability she was experiencing during her medical treatment. Instead, I heard him say, "Jennifer, you mean more to me than any patient I've ever treated. What we have is special, and I care about you in ways that go far beyond medicine." My blood ran cold. This was it. This was the moment I knew with absolute certainty that Dr. Marcus Evans was not just crossing professional boundaries. He was deliberately manipulating vulnerable patients for his own gratification. I stood in that hallway for several minutes, processing the full implications of what I had just witnessed, understanding that I now had knowledge that came with enormous responsibility. I spent the rest of that night wrestling with what to do with this information. I could report it immediately, but I knew that without concrete evidence, it would be his word against mine, and everyone knew who would be believed in that scenario. I could confront Dr. Evans directly, but that would likely just make him more careful about concealing his behavior while potentially putting Jennifer and other patients at greater risk. I could try to warn Jennifer about what was happening, but she was so emotionally dependent on Dr. Evans that she would likely reject any suggestion that he was manipulating her. So I made the decision that would define the next several years of my career. I decided to document everything. Every inappropriate interaction, every boundary violation, every decision that prioritized Dr. Evans' personal interests over patient care. I would build a case so comprehensive and undeniable that when the time came to act, no one would be able to dismiss or ignore what I had uncovered. The documentation process was exhausting and emotionally draining. I had to watch, day after day, as Dr. Evans continued to manipulate Jennifer and other vulnerable women, knowing that my intervention could help them, but also knowing that premature action might allow him to escape consequences entirely. I felt like I was complicit in their suffering by not acting immediately, but I also understood that building an airtight case was the only way to ensure that justice would be served and future victims would be protected. Jennifer's relationship with Dr. Evans continued for another 8 months, before it reached its inevitable conclusion. Like all predators, Dr. Evans eventually grew tired of her, once the thrill of the conquest faded, and the relationship became more demanding than rewarding. He began distancing himself from her, delegating her care to residents and other attending physicians, reducing the frequency of his visits, and showing less interest in her personal stories and emotional states. Jennifer was devastated by this change in his behavior. She couldn't understand why her special relationship with Dr. Evans was ending, why he suddenly seemed less interested in her well-being, why their conversations had become brief and clinical. She began experiencing anxiety and depression that significantly impacted her recovery from her final surgery, and she started making increasingly desperate attempts to recapture Dr. Evans's attention and affection. The end came when Jennifer, in a moment of desperation and confusion, told Dr. Evans that she loved him and asked if they could continue their relationship outside of the hospital setting. I wasn't present for this conversation, but I learned about it from Jennifer herself, who sought me out afterward because she needed to talk to someone about what had happened. Dr. Evans had rejected her advance, not with kindness or therapeutic redirection, but with cold dismissal and professional distance that left Jennifer feeling humiliated and abandoned. He told her that she had misunderstood their relationship, that he had simply been providing compassionate care, and that her feelings were a common psychological response to medical treatment that would fade once her health improved. Jennifer was discharged from our care shortly afterward, her medical treatment complete but her emotional state shattered. I watched her leave the hospital that day, knowing that she had been systematically manipulated and discarded by someone she had trusted with her life, and knowing that Dr. Evans was already identifying his next victim. That victim would be Maria Santos, a 28-year-old immigrant woman with limited English skills and no family support system in the United States. Maria needed a series of cardiac procedures to address complications from rheumatic fever she had experienced as a child. Her vulnerability was even more pronounced than Jennifer's because of her linguistic and cultural isolation, her uncertain immigration status, and her complete dependence on the hospital staff for communication and support. Dr. Evans' pattern with Maria was more sophisticated, more calculated, and more disturbing than what I had observed with Jennifer. He positioned himself as not just her doctor, but as her cultural interpreter, her advocate with immigration services, her primary source of information about American healthcare systems. He arranged for extended stays that weren't medically necessary, claiming that her case required careful monitoring due to complications that other doctors couldn't detect. The gifts for Maria were more personal and more expensive than what he had given Jennifer. Designer clothing that he claimed had been donated to the hospital, jewelry that he said was from grateful former patients, electronic devices that he insisted she needed for her recovery and rehabilitation. Each gift came with stories about how he had advocated for her with hospital administration, how he had pulled strings to get her the best possible care, how he was protecting her from other staff members who didn't understand her cultural needs. Maria's gratitude toward Dr. Evans was profound and heartbreaking to witness. She saw him as her savior in the most literal sense, the person who had not only saved her life, but had also provided her with care and respect in a foreign country where she felt lost and vulnerable. Her limited English skills made it difficult for her to communicate with other staff members, so she became even more dependent on Dr. Evans for information, reassurance, and emotional support. The manipulation tactics Dr. Evans used with Maria were more subtle and more sophisticated than what I had seen before. He would share carefully selected details about his own life, creating a false sense of intimacy and mutual trust. He would ask about her family in her home country, her fears about her immigration status, her hopes for her future in America. He positioned himself as someone who understood her struggles and was committed to helping her navigate not just her medical treatment, but her entire adjustment to life in a new country. I watched this relationship develop over months, documenting every inappropriate interaction, every boundary violation, every decision that prioritized his personal access to Maria over her actual medical needs. The pattern was becoming clearer and more disturbing with each new victim. Dr. Evans wasn't just taking advantage of opportunities that presented themselves. He was actively selecting vulnerable women, creating dependencies, and systematically grooming them for exploitation. The late-night visits with Maria were longer and more frequent than what I had observed with Jennifer. Dr. Evans would arrive at her room with takeout food from expensive restaurants, claiming he wanted to ensure she was eating well during her recovery. They would share meals while he told her stories about his travels, his education, his important position at the hospital. He would bring music from her home country, photos of places he claimed he wanted to visit, books about her culture that he said he was reading to better understand her background. Maria began dressing more carefully for Dr. Evans' visits, asking other staff members to help her with makeup and hairstyling, expressing excitement about the time she would spend with him each evening. She would save up stories and questions throughout the day, clearly viewing these visits as the highlight of her hospital experience. The emotional dependency was obvious and disturbing, but Maria interpreted her feelings as gratitude and friendship rather than recognizing the manipulation that was occurring. The sexual component of Dr. Evans's relationship with Maria became apparent when I walked in on one of their evening visits and found them in physical contact that was clearly inappropriate. Dr. Evans was massaging Maria's shoulders and neck, claiming he was helping her with tension and pain that wasn't being addressed by her prescribed medications. Maria was clearly uncomfortable, but was trying to be polite and grateful, not understanding that what was happening was a violation of professional boundaries and potentially criminal behavior. When I entered the room, Dr. Evans immediately stepped away from Maria and began talking about her medical progress in a loud, professional tone that was clearly intended to cover what had been happening before I arrived. Maria looked confused and embarrassed, pulling her hospital gown more tightly around herself and avoiding eye contact with both of us. I completed my routine check quickly and left the room, but I spent the rest of that night documenting everything I had observed and struggling with the knowledge that I had just witnessed what was likely sexual assault of a vulnerable patient. The relationship between Dr. Evans and Maria continued for several more weeks before reaching its conclusion in a way that was even more disturbing than what had happened with Jennifer. Rather than simply losing interest and distancing himself, Dr. Evans began using Maria's immigration status as a tool of control and manipulation. He started making comments about how her continued treatment might be affected by changes in immigration policy, how her legal status could impact her ability to receive care, how he might be able to help her navigate these challenges if she was especially grateful for his assistance. Maria, already completely dependent on Dr. Evans for medical care and emotional support, became terrified that she might lose access to treatment or face deportation if she didn't maintain his favor. The power dynamic, already heavily skewed in his favor, became even more coercive as he used her legal vulnerability as leverage to ensure her compliance and silence. The end of Maria's relationship with Dr. Evans came when her medical treatment was complete, and she could no longer justify extended hospital stays. Unlike Jennifer, who had been discarded when Dr. Evans lost interest, Maria was dismissed because her usefulness as a victim had expired. Dr. Evans arranged for her discharge with minimal follow-up care, despite the fact that her condition typically warranted ongoing monitoring and support. Maria's departure from the hospital was heartbreaking to witness. She clearly expected to maintain some kind of ongoing relationship with Dr. Evans, asking about follow-up appointments, expressing concern about how she would manage her recovery without his guidance, seeking reassurance that he would continue to be available if she had questions or problems. Dr. Evans' responses were professionally polite but emotionally cold, making it clear that their relationship was ending with her discharge. I watched Maria leave the hospital that day, understanding that she was confused and hurt by Dr. Evans' sudden emotional unavailability, but probably not fully comprehending that she had been systematically manipulated and exploited. Her limited English skills and cultural isolation meant that she was unlikely to recognize what had happened to her as abuse, and even less likely to report it or seek support. Between Maria's discharge and Emily's arrival, there were 2 other patients who followed similar patterns with Dr. Evans. Rebecca Thompson, a 41-year-old woman going through a difficult divorce while dealing with a cardiac condition that required multiple procedures. And Lisa Park, a 26-year-old graduate student whose academic career was interrupted by a congenital heart defect that necessitated complex surgery and extended recovery. Both women experienced the same pattern of manipulation: excessive personal attention, inappropriate gifts, boundary violations, late-night visits, gradual isolation from other care providers, and eventual discard when their treatment was complete, or Dr. Evans lost interest. Both women left the hospital emotionally damaged by relationships they didn't understand were exploitative, grateful for what they perceived as exceptional care, while simultaneously confused by the emotional pain they felt when the relationships ended. By the time Emily Chen arrived at our hospital, I had been documenting Dr. Evans' pattern of behavior for over 3 years. I had detailed records of his interactions with 5 different patients, clear evidence of systematic boundary violations, comprehensive documentation of medical decisions that prioritized his personal access over patient care, and witness statements from other staff members who had observed concerning behavior. But I still hadn't acted on this information, because I knew that challenging someone with Dr. Evans' reputation and institutional power required not just evidence, but perfect evidence. I needed documentation that was so comprehensive and undeniable that no one could dismiss it, rationalize it, or cover it up. I needed a case that would not only remove Dr. Evans from his position, but would also create systemic changes that would protect future patients from similar predators. Emily's case would provide me with that perfect evidence, but at a cost that still haunts me. I had to watch another vulnerable woman being systematically manipulated and exploited, knowing that I could potentially stop it, but also knowing that premature action might allow Dr. Evans to escape consequences entirely and continue his predatory behavior with better concealment and more sophisticated tactics. The ethical weight of this decision, to allow Emily to suffer in the short term in order to build a case that would protect countless future victims, was almost unbearable. Every day, I watched Dr. Evans continue his manipulation. Every night I documented his violations, and every moment I questioned whether I was making the right choice by building a comprehensive case rather than acting immediately to protect Emily. But I also understood that my previous documentation of his behavior with Jennifer, Maria, Rebecca, and Lisa had prepared me to recognize and record his tactics with Emily in unprecedented detail. I knew what to look for. I understood the pattern, and I was able to document not just the individual violations, but the systematic nature of his predatory behavior. Emily's arrival at our hospital marked the beginning of the end for Dr. Marcus Evans, though neither of them knew it at the time. Emily represented the perfect storm of vulnerability that attracted predators like Dr. Evans. Young, attractive, isolated, dealing with a chronic condition that required ongoing medical care, and emotionally fragile due to the impact of her illness on her social relationships and professional prospects. But Emily also represented something else. The final piece of evidence I needed to build an unassailable case against Dr. Evans. Her case would provide the clear, undeniable proof of systematic predatory behavior that would finally bring justice for all of his victims and protection for all of his potential future victims. The documentation process for Emily's case was more intensive and more systematic than anything I had done before. I recorded not just Dr. Evans' inappropriate behavior, but also Emily's responses, the impact on her emotional state and recovery process, the reactions of other staff members, and the institutional factors that enabled and protected his predatory behavior. I documented every gift he gave her, taking photographs when possible and recording detailed descriptions when photography wasn't feasible. I noted the timing and duration of his visits, the topics of their conversations when I could overhear them, and the changes in Emily's behavior and emotional state that corresponded with his manipulation tactics. I recorded his medical decisions regarding Emily's care, comparing them with standard protocols and noting instances where his choices seemed motivated by personal rather than medical considerations. I documented his isolation tactics, recording instances where he dismissed or overruled other healthcare providers' recommendations regarding Emily's treatment. Most importantly, I documented the impact of Dr. Evans' behavior on Emily's recovery and well-being. I recorded instances where his manipulation seemed to increase her anxiety and emotional dependency, times when his inappropriate attention seemed to interfere with her engagement with other aspects of her care, and moments when his boundary violations clearly made her uncomfortable, even as she tried to remain grateful and compliant. The level of documentation I maintained during Emily's case was exhaustive and emotionally draining. I felt like I was living a double life, maintaining my professional duties as a nurse while simultaneously conducting an undercover investigation of one of the hospital's most respected physicians. The constant vigilance required to observe and record Dr. Evans' behavior without being detected was mentally exhausting, and the emotional toll of watching Emily being manipulated was almost unbearable. But I also knew that this documentation was building toward something significant. Every piece of evidence I collected was another nail in Dr. Evans' professional coffin, another layer of protection for future patients, another step toward justice for the women he had already victimized. The night that Dr. Evans humiliated me in the operating room wasn't just a turning point in Emily's case. It was the moment when my professional obligation to build a comprehensive case aligned with my personal motivation to see justice served. The man who had spent years manipulating vulnerable women had finally made the mistake of underestimating someone who had been systematically documenting his crimes. His arrogance in dismissing my legitimate medical concerns in front of Emily wasn't just unprofessional. It was a demonstration of the same sense of superiority and entitlement that enabled his predatory behavior. In that moment, he revealed that he viewed everyone around him, not just his victims, as subordinate to his will and inferior to his judgment. But what Dr. Evans didn't understand was that his dismissive comment about me being just a nurse was being made to someone who had spent 3 years building the most comprehensive documentation of medical misconduct and predatory behavior that our hospital system had ever seen. He was sneering at someone who held the power to destroy not just his career, but his freedom and his future. The weeks following that humiliating encounter in the operating room were the most intense period of my documentation efforts. I knew that the time for building evidence was coming to an end, and that soon I would need to act on everything I had collected. The thought of finally confronting the institutional systems that had protected Dr. Evans for so long was both terrifying and exhilarating. I spent hours refining my documentation, organizing evidence chronologically and thematically, cross-referencing witness statements with objective records, and building a narrative that would be compelling and undeniable to anyone who reviewed it. I created timelines, compiled photographic evidence, gathered corroborating statements, and prepared comprehensive analyses of the medical and ethical violations I had observed. The report I eventually submitted was not just a collection of complaints about inappropriate behavior. It was a comprehensive indictment of a predatory physician and the institutional systems that had enabled his crimes. It demonstrated systematic patterns of patient exploitation, documented specific instances of medical negligence motivated by personal interests, and provided evidence of a culture of silence and complicity that had allowed these violations to continue unchecked. But perhaps most importantly, my report provided a roadmap for institutional change that would prevent future victims and hold healthcare providers accountable for maintaining appropriate professional boundaries. It wasn't enough to remove Dr. Evans from his position. The systems that had protected him needed to be reformed to ensure that similar predators couldn't operate with impunity in the future. The investigation that followed my report was thorough, professional, and ultimately devastating for Dr. Evans and his enablers within the hospital system. Every piece of evidence I had collected was verified. Every witness statement was corroborated, and every allegation was substantiated through independent investigation. The scope of Dr. Evans's misconduct was even more extensive than what I had documented. The investigation revealed additional victims who came forward once they understood that their experiences were part of a systematic pattern of abuse. Financial irregularities were discovered that demonstrated how Dr. Evans had been exploiting the healthcare system for personal gain while manipulating vulnerable patients. The institutional response was swift and comprehensive. Dr. Evans was immediately terminated, his medical license was suspended pending criminal investigation, and multiple lawsuits were filed by former patients who had been victimized by his predatory behavior. The hospital implemented new policies and procedures designed to prevent similar misconduct, and several administrators who had failed to address earlier concerns about Dr. Evans's behavior were disciplined or terminated. But the most satisfying aspect of the investigation's outcome was seeing the women who had been victimized by Dr. Evans finally receive validation, support, and justice. Jennifer, Maria, Rebecca, Lisa, and Emily all participated in the investigation and legal proceedings, sharing their experiences and helping to build the comprehensive case that ultimately led to Dr. Evans' criminal conviction. Watching these women reclaim their power and their voices after being systematically manipulated and silenced was profoundly moving. They had been isolated and exploited by someone who was supposed to heal them, but through the investigation and legal process, they found their strength and their courage to speak truth to power. Emily's recovery, both medical and emotional, was particularly meaningful to witness. Once she was removed from Dr. Evans' manipulative influence and provided with appropriate medical care from ethical physicians, her condition improved dramatically. More importantly, she began to understand that her feelings for Dr. Evans had been manufactured through systematic manipulation, and that her special relationship with him had actually been a form of abuse. The criminal trial of Dr. Marcus Evans was a landmark case that received significant media attention and became a catalyst for broader conversations about power, consent, and professional boundaries in healthcare settings. His conviction on multiple charges including sexual misconduct, prescription fraud, and insurance fraud sent a clear message that predatory behavior by healthcare providers would not be tolerated or covered up. The 18 months Dr. Evans served in prison were just the beginning of his consequences. His medical license was permanently revoked. He was banned from working in any healthcare-related capacity, and he faced numerous civil lawsuits that left him financially ruined. The man who had once commanded respect and fear in hospital corridors became a cautionary tale about the dangers of unchecked power and institutional complicity. But perhaps more importantly, the case led to systemic changes in how healthcare institutions address misconduct allegations, how they monitor physician-patient relationships, and how they support healthcare workers who raise concerns about unethical behavior. The policies and procedures that were implemented as a result of Dr. Evans' case have protected countless patients and healthcare workers from similar predatory behavior. The personal impact of this experience on my own career and life has been profound and lasting. I learned that one person with documentation, determination, and courage can make a difference even when confronting seemingly untouchable people and institutions. I discovered that the most effective form of justice isn't personal revenge, but systematic change that protects vulnerable people and holds powerful people accountable. I also learned about the enormous personal cost of standing up to institutional power and challenging people who seem untouchable. The investigation and legal proceedings were emotionally exhausting, professionally risky, and personally isolating. There were colleagues who resented me for causing trouble, administrators who viewed me as a threat to institutional stability, and moments when I questioned whether the personal sacrifice was worth the potential benefits for others. But every time I doubted my decision to challenge Dr. Evans and the systems that protected him, I thought about Jennifer, Maria, Rebecca, Lisa, and Emily. I thought about the women who would never become his victims because he had been stopped. I thought about the healthcare workers who would feel empowered to speak up about unethical behavior because my case had demonstrated that institutional change was possible. Today, 7 years after I first began documenting Dr. Evans' predatory behavior, I continue to work as an operating room nurse in the same hospital where these events occurred. The institutional culture has changed dramatically as a result of the policies and procedures that were implemented following his case. Healthcare workers are better trained to recognize boundary violations. Patients are better informed about their rights and protections, and there are clearer mechanisms for reporting and addressing concerns about unethical behavior. I still encounter physicians who are arrogant, dismissive, or disrespectful toward nursing staff, but I no longer see the systematic predatory behavior that characterized Dr. Evans' practice. The message sent by his prosecution and the institutional changes that followed have created an environment where such behavior is less likely to occur and more likely to be reported and addressed if it does occur. The other nurses who work with me know about my role in the Dr. Evans case, and many of them have told me that they feel more confident about speaking up when they observe concerning behavior, because they know that institutional support exists for healthcare workers who raise legitimate concerns. The culture of silence and complicity that once protected predatory physicians has been replaced by a culture of accountability and patient advocacy. Emily Chen, whose case provided the final evidence needed to bring down Dr. Evans, has become a patient advocate herself, working with healthcare institutions to improve policies and procedures related to patient safety and professional boundaries. Her experience as a victim of medical predation has become a source of strength and purpose, as she works to ensure that other vulnerable patients receive appropriate protection and care. The other women who were victimized by Dr. Evans have also found ways to transform their traumatic experiences into advocacy and activism. Jennifer has become involved in legal reform efforts related to medical malpractice and professional misconduct. Maria has worked with immigrant rights organizations to improve healthcare access and cultural competency for vulnerable populations. Rebecca and Lisa have both become active in patient advocacy organizations focused on protecting vulnerable people from medical exploitation. Seeing these women reclaim their power and use their experiences to protect others has been one of the most rewarding aspects of this entire ordeal. What began as systematic victimization by a predatory physician has evolved into a network of advocacy and activism that continues to protect vulnerable patients and support healthcare workers who speak up about unethical behavior. The broader impact of the Dr. Evans case extends far beyond our hospital and our community. The legal precedents established by his prosecution have been cited in similar cases across the country, and the institutional reforms implemented as a result of his misconduct have been adopted by healthcare systems nationwide. What started as one nurse documenting concerning behavior has become a catalyst for systemic change that protects patients and healthcare workers across the entire healthcare industry. But the most important lesson I learned from this experience is that institutional change requires individual courage. Systems of power and privilege don't reform themselves. They change because individuals are willing to challenge them, even when doing so involves personal risk and professional sacrifice. The policies and procedures that now protect patients and healthcare workers exist because one person was willing to document systematic misconduct and challenge institutional complicity. Dr. Marcus Evans thought he was untouchable because of his reputation, his institutional power, and his network of enablers. He believed that his victims would remain silent because of their vulnerability and dependency, and that his colleagues would continue to look the other way, because challenging him would be professionally risky and personally uncomfortable. He was wrong on all counts. His victims found their voices and their strength when they understood that their experiences were part of a systematic pattern of abuse. His colleagues and the institutional systems that had protected him were forced to confront the reality of his predatory behavior when presented with comprehensive, undeniable evidence. And one nurse, who he dismissed as insignificant and powerless, proved to be the architect of his downfall. The phrase that sealed Dr. Evans's fate, "You're just a nurse," became the title of this story because it represents everything that was wrong with his worldview and everything that was right about the justice that ultimately destroyed him. He saw nursing staff as subordinate, powerless, and unworthy of respect, never imagining that one of those just nurses possessed the skills, determination, and courage to build the case that would end his career and send him to prison. Being just a nurse meant that I was trained to observe patients carefully, to document everything thoroughly, to advocate for patient safety even when doing so was difficult or unpopular, and to maintain professional ethics even when powerful people tried to intimidate or silence me. Being just a nurse gave me the skills and the motivation I needed to bring down a predator who had been exploiting vulnerable patients for over a decade. The revenge I took against Dr. Evans wasn't motivated by personal anger or professional ego. It was motivated by professional responsibility and moral obligation. He needed to be stopped, not because he had humiliated me, but because he was systematically harming vulnerable people who trusted him with their lives. The satisfaction I felt when he was finally brought to justice wasn't about personal vindication. It was about knowing that future patients would be protected from his predatory behavior. This is what real revenge looks like. Not petty retaliation or personal satisfaction, but systematic justice that protects the innocent while holding the guilty accountable for their actions. It's about using your skills, your knowledge, and your position to create positive change that extends far beyond your personal grievances or individual circumstances. Today, when I encounter healthcare workers who are struggling with concerns about unethical behavior but feel powerless to address it, I tell them the story of Dr. Marcus Evans and remind them that one person with documentation, determination, and courage can make a difference. Institutional change is possible, justice can be achieved, and predators can be stopped. But only if individuals are willing to take the personal and professional risks required to challenge systems of power and privilege. The hospital corridors where I work every day are safer now because one nurse refused to stay silent about systematic misconduct. The patients who receive care in our facility are better protected because one healthcare worker was willing to document concerning behavior and challenge institutional complicity. The culture of our workplace has been transformed because one person believed that professional ethics and patient safety were more important than personal comfort and career security. That's the real power of being just a nurse. The power to observe, to document, to advocate, and to act when action is required to protect vulnerable people from those who would exploit and harm them. It's the power to transform individual courage into institutional change, to turn systematic documentation into systematic justice, and to ensure that the people who seem most untouchable are held accountable for their crimes. Dr. Marcus Evans learned too late that respect earned through fear and intimidation is just an illusion, and that when your crimes are exposed to the light, all the reputation and influence in the world can't save you from the consequences of your actions. He discovered that the person he dismissed as just a nurse possessed the power to wield a force more powerful than his own scalpel, the unwavering courage to protect her patients, and the cold, hard evidence to hold a God accountable. If you believe the best revenge is the one that not only punishes the guilty, but also protects the innocent, show your support with a like, and subscribe to Hospital Revenge for more stories from the inside. And let us know in the comments, what do you think makes revenge truly satisfying?